So next is blunt chest trauma V8, and you are called to a 55-year-old male in Visas. He was the unrestrained driver of a car that has been involved in head-on collision with an articulated truck. He is hypoxic with a saturation of 90% on the room air. His blood pressure is 80 over 60. What would be causing his hypoxia? So, from the mechanism of injury, it should be assumed that he has suffered bilateral rib fractures and likely flail segment. This is likely to have resulted in underlying lung contusion, and he may also have bilateral pneumothorax that may be simple, open, or so multiple rib fracture with flail segment and human pneumothorax may be open, tension, or simple. So non-ventilated and non-perfused areas of the lungs result in the blood flow shunts and VQ mismatch. This may be confounded by other injuries in other body regions causing hypovolemia. How should we manage? So he should be managed by ATLS principles. He requires concurrent management and investigation with the priority given to the life-threatening injuries such as the tension pneumothorax. He requires high flow oxygen, optimal analgesia, include PCR regional analgesia. If he continues to be hypoxic, then he will be require intubation and ventilation to optimize ventilation. Pneumothoraxes and hemothoraces should be drained by the placement of thoracostomies, followed by an underwater intercostal drain. He is hypotensive and should be actively associated with the blood and blood products, code red or methyltransfusion protocol. The seriousness of his injuries requires that the trauma team should be made up of senior and experienced clinicians. How do blast injuries produce hypoxia? The combination of diffuse pulmonary contusions, pneumothorax, and pulmonary hemorrhage and arteriovenous fistula resulting in air emboli. How can blunt chest trauma compromise the cardiac output? Again, blunt chest trauma, massive hemothorax and hypovolemia, chest wall injury and bleeding from fracture site, intercostal vessel, lung parenchymal bleeding, hilar vessel injury and major vessel aorta and IVC injury. And then is the tension pneumothorax causing collapse and shift of the mediastinum. Pressure on the thin walled SVC, superior vena cava, inferior vena cava is reduced venous return and subsequent reduced cardiac output. Cardiac tamponade, cardiac contusion, cardiac ischemia, infarction, and valve disruption. How do we assess patient with thoracic injuries? So follow the ATLS principles during the primary survey. Evaluate the neck, like any airway obstruction, neck injury, tracheal deviation, chest wall symmetry, expansion, open wound, flail segment, rib burst, tunnel fracture, pleura, pneumothorax, hemothorax, air or bullet entry and exit wounds, objects transfixing the thoracic cavity. Obtain chest X-ray or chest fast scanning during immediately after the primary survey. This patient chest X-ray shows rib fracture but no pneumothorax. He has no clinical signs of major thoracic trauma. He is still hypotensive and hypoxic despite blood resuscitation and clinical unstable. What are you going to do? You should undergo abdominal fast scan to assess for intra-abdominal free fluid. His mechanism is that of deceleration injury. He is at risk of splenic, hepatic, mesenteric, renal, bowel injury. He may also have an aortic injury. So, if he remains unstable despite resuscitation, then he should be having a trauma laparotomy with exploration of the bleeding source from solid organ, hollow organ, retroperitoneal structures, and major vessels and the pelvis. If he responds to resuscitation, then an opportunity may rise to get more diagnostic information in the form of CT to rule out aortic injury. If not, you have damage control surgery and only when stable undergo post-operative CT imaging. At laparotomy, his peritoneal cavity and retroperitoneal normal. What is the next course of action? No intra-abdominal source of blood has been found. Make a pericardial window from below to rule out cardiac tamponade. If is positive, then proceed to median sternotomy or left anterolateral or clamshell thoracotomy. Aortic injury is best treated by thoracic endovascular aortic repair. Patients with catastrophic aortic injury die on the scene, and those with a contained injury often survive to permit repair. Spinal injury also needs to be ruled out as a cause of persistent hypotension, particularly with good peripheral perfusion. This patient with multiple anterior fractures and flail segments deteriorates very quickly in the resuscitation room. He loses his cardiac output and his end tidal carbon dioxide plummets. How would you manage him now? This patient is now agonal and is now about to go into the cardiac arrest. He should be intubated and have bilateral thoracotomies to preemptively treat the tension pneumothorax that may or may not have occurred. Should be immediately transferred blood and blood products. Closed chest cardiac massage will further damage the underlying lungs. Immediate systemic thoracotomy permits immediate diagnosis and treatment of any intrathoracic injury. Aortic pressure and proximal vascular control improves cerebral and myocardial perfusion. The pericardium must be opened and internal cardiac massage after the cardiac filling can take place. In the event of torrential lung injury, proximal hilar control can be gained by twisting the lung around the hilum or placing a soft clamp across the hilum. And bleeding from the intercostal can be packed. If cardiac activity returns, the patient should be transferred immediately to the operating center for further exploratory surgery and effort to remove the aortic limb. If the heart fails to start, then further resuscitation efforts should cease. It is understood that systemic thoracotomy for blunt trauma cardiac arrest is associated with poor outcomes and has a high mortality, but in these circumstances, every effort has been made to try to preserve the life. Thank you.